Il est bientôt 9 h. Bonjour à tous. En attendant de lancer cette plénière consacrée aux trosses de l'enfant, juste pour vous rappeler qu'il y a une traduction simultanée en flashant le code qui est plus sur l'écran mais sur votre badge maintenant. Et pour ceux qui préfèrent la version française et en l'immédiat, dans l'autre amphithéâtre, vous êtes accueillis. Donc, nous avons le plaisir d'accueillir le professeur Verhulst pour cette plénière sur les trosses de l'enfant, un de ses domaines de prédilection, comme vous le verrez, tant pour ses recherches que dans sa pratique clinique. Il est professeur de pédiatrie à l'unité d'Anvers, chef de département de pédiatrie à l'hôpital universitaire d'Anvers, très impliqué dans les instances internationales, notamment à l'European Respiratory Society, pour laquelle il a été rédacteur de nombreuses task force sur les trosses. Il nous parle aujourd'hui du lien de causalité entre trosses et morbidité, un sujet passionnant. J'espère que vous aurez plaisir à l'écouter et je le remercie encore vivement d'être parmi nous ce jour. Merci beaucoup.
Good morning, everyone. Thank you for the invitation. It's a pleasure and true honor to be here and to present this very important topic on the relation between obstructive sleep apnea in children and morbidity, with kind of a difficult question, cause or consequence. Now, when you talk about morbidity in children with obstructive sleep apnea syndrome, you can only start with the chat study. This also means that when we start with the chat study, we have 10 years of research to summarize, which is quite a difficult task, but I will try to do this for you. But I'm afraid that we will end up with more questions than really answers. So about 10 years ago, the chat study was published, and this was a very important study for our field, because this was the first, perhaps also the only randomized controlled trial that we have in our field. And it investigated in a randomized controlled trial design the effects of adenotonsillectomy on neurocognitive functioning in children with mild sleep-disordered breathing. And there was a lot to do about the chat study, first and foremost because it was a negative study. This was the primary outcome, the NEPSI score. It's a score reflecting neurocognitive executive functioning. But as you see here, there was no significant effect or no significant improvement in the children who received adenotonsillectomy compared to the control group, who consisted of children where the watchful waiting approach was handled. Now, for me, this was not the main finding of the chat study. The main finding for me of the chat study was that nearly 50% of the children in the control group, in the watchful waiting group, they showed a normalization of their apnea-hypopnea index. So they were cured with just waiting, without an intervention. And this is a very important finding that really makes the management, the approach that we have to children with milder forms of sleep-disordered breathing really difficult. And there was a lot to do about it, and I always pick this review, which was published in Pediatrics, one of the main journals in the field of general pediatrics, where they discussed the topic about overdiagnosis. And because of the findings of the chat trial, they included obstructive sleep apnea as one of the diseases where a possible diagnosis could be harmful for children. If you also have a large proportion of children that will just be cured over time, then possible this diagnosis will lead to unnecessary and possibly harmful interventions. So this is a very important subgroup of patients to consider. And of course, one of the main advantages of doing a very large randomized controlled trial is that you can do a lot of secondary and tertiary analysis. And this is one of the, perhaps one of the most important papers originating from the chat study, where they looked specifically at those children with a spontaneous resolution of obstructive sleep apnea over time. What were the characteristics of these children? And for me, very important is that these were mainly children without a lot of symptoms. These children had an absence of snoring, an absence of loud snoring, and a very low PSQ, which is a questionnaire that a lot of us are using in daily practice. So a lower PSQ questionnaire, a lower snoring score were independent predictors of a spontaneous resolution over time. So the conclusion that we need to make from the CHAT study is that there is a subset of patients with an apnea-hypopnea index in the abnormal range, but without clear symptoms, perhaps also without clear morbidity. So those children are certainly at risk for overdiagnosis. And of course, we identified certain risk factors for either persistence, we didn't go into that, or resolution. Just between brackets, I also have to make the point that we are also still underdiagnosing obstructive sleep apnea in children. And we have sometimes normal infants with failure to thrive, where no one thought about the possibility of obstructive sleep apnea. And certainly in children with underlying syndromes, they have a very high prevalence of obstructive sleep apnea. So this is certainly, these are certainly children where you need to actively screen for obstructive sleep apnea. So this brings us to the overview of my talk. So when we put morbidity central, how can we address those children with milder OSA and also those children with mild snoring? And we will talk about cause and consequence as well. From that point, we will move on to a specific subset of children, mainly to obese children, where we look at the link between obstructive sleep apnea and metabolic or cardiovascular morbidity. And last, I included some few recent slides on studies about the microbiome and pediatric OSA. And the microbiome, we know it's everywhere, it's a hot topic, and it also found its way into the field of adult and pediatric obstructive sleep apnea. So let's first focus on primary snoring and mild obstructive sleep apnea. First and foremost, I think it's essential that whatever we do, we think about the syndrome. We do not only think about the numbers. The CHAT study and many other studies have made that perfectly clear. Just as in adults, also in children, the apnea-hypopnea index is not the holy grail. It has no universal relation with morbidity, and it should always be put in context to symptoms, to risk factors for persistence or spontaneous resolution, and also in context to morbidity. But there, for us, it's very difficult because morbidity in the child with obstructive sleep apnea is not always easy to measure. 10 to 12% of children snore. We don't have the possibility to do IQ tests or to do blood tests or to do tests for endothelial functions in 10 to 12% of the population of snoring children. So we need better tools. One pathway to that could be to improve the apnea-hypopnea index. This is one older study from the group of Brigitte Faroux, where they looked at pulse wave amplitude reduction as another measure, easy measure for cortical arousals during sleep hypopneas, mainly hypopneas in children. We will not go into detail about this study, but I think that we need to improve the apnea-hypopnea index. And by further incorporating other measures of sleep disruption that are perhaps easy to measure, such as a pulse wave amplitude reduction, could perhaps improve the apnea-hypopnea index so that it better correlates or is better predictive of morbidity. This is another example of the group of Roberto Hornero, who is doing a lot of work with machine learning in the diagnosis of obstructive sleep apnea in children, where here they have tried to improve the overnight EEG so that it better reflects EEG irregularity or sleep disruption. And I think both of these studies are examples on how to improve our diagnostic capacities so that the numbers that we get better reflect morbidity in the individual patient. Another way of looking could be the use of biomarkers. And unfortunately, the research on biomarkers in children is still relatively limited. This is a very interesting study from the group of David Kozal, who of course did a lot of work, did tremendous work on obstructive sleep apnea in children, especially looking at linking mechanisms between sleep apnea and morbidity. And here they specifically looked at urinary neurotransmitters, biomarkers, that could predict which children with obstructive sleep apnea, had also an abnormal neurocognitive function. And you see here that the numbers of certain neurotransmitters were significantly altered in the group with OSA and with neurocognitive abnormalities compared to the group with OSA but without morbidity. So I think that this is really one of the ways to move our field forward. And this is a review, again, from 5-6 years ago, looking at different research on possible biomarkers that could be useful in this context. The next question, and that's the most clinically relevant question, is, okay, how to really address primary snoring and mild OSA in our daily clinical practice? So the main setting here is, should we as physicians treat those children with mild OSA, including children with primary snoring, should we treat them aggressively, for instance, with adenotonsillectomy? And factors to consider in favor are that we know from the vast amount of research that there is an absolute positive effect of adenotonsillectomy on nocturnal breathing parameters. And not on all, but on several OSA-related complications, there's absolutely a positive effect of this surgery. On the other hand, we also know, and we talked about that there's no clear-cut correlation between the improvement in complications and the improvement in the apnea-hypopnea index. We talked about the importance of the syndrome in patient selection. Symptoms, morbidity play an essential role. But what also makes it difficult is that there are a number of studies that clearly show that children with primary snoring, so snoring without apneas, without hypopneas, also exhibit morbidity. And of course, this has huge implications for the possible scope of the problem, because then you need to treat 10 to 12% of the pediatric population. This is, for instance, a systematic review that looked at the relation between different degrees of sleep-disordered breathing and neurocognitive morbidity. We will not go into detail, but you can see, for instance, that here for problem solving, that children with primary snoring do have a worse score compared to children with milder OSA. And this is, for instance, also true for processing speed and different other measures of neurocognitive functioning. So this review, the systematic review, concluded that children with primary snoring experience comparable, but sometimes also higher levels of cognitive deficits to children with obstructive sleep apnea. And this makes the setting very difficult, because we have to treat who? We have to decide who do we treat, why do we treat, and of course, how do we treat these children? So some open questions. For children with primary snoring and mild OSA, we have a lot of these children. Who's at risk of morbidity? You can ask yourself the question, do we still need a sleep study if primary snoring is associated with neurocognitive morbidity? How can we easily identify these children in daily clinical practice? And for those children with a high symptom burden, it's an easy decision. But what to do, and we all know these children, what to do in children with no or subclinical symptoms. So we really have to think, and we really have to do more research into how sleep-disordered breathing, through the well-known mechanisms of intermittent hypoxia, sleep fragmentation, inflammation, oxidative stress, endothelial dysfunction, lead to neurocognitive or end-organ morbidity. For children with primary snoring, it becomes somewhat more difficult, because you cannot talk about intermittent hypoxia in children with primary snoring because they do not exhibit apneas and hypopneas. So we really need more research into the linking mechanisms, linking also milder forms of sleep-disordered breathing, primary snoring, with neurocognitive morbidity. And is it important? Yes, it is important. And this is, for instance, illustrated with brain imaging studies in children with obstructive sleep apnea. And it's mainly the group of David Kozel who did a lot of work in that, and I will show you some study. This is one of the first studies showing that children with pediatric obstructive sleep apnea had in certain areas of the brain reduced regional gray matter volumes. And these children also had a significant lower IQ compared to the control group. In another study, they investigated another marker called brain tissue integrity, and they specifically found that certain areas in the brain, mainly associated with attention, neurocognitive function, executive functions, were significantly altered in children with obstructive sleep apnea. And this last Chinese study also found that these regional brain changes, that they significantly correlated with lower scores in neurocognitive functioning tests. So this is certainly troublesome. Children with obstructive sleep apnea, they have abnormal brain imaging, which also correlates with less neurocognitive functioning. So the main question is this cause or effect? And frankly, we do not know. I think it's most likely a cause. But we have to be aware that we have no imaging studies, no brain imaging studies so far controlling the brain imaging after treatment. But why do I say that it is that I think it's the effect? Because the abnormalities that are detected using the brain imaging are mainly located in the neurocognitive areas and not in the respiratory areas of the brain. Another finding that supports this hypothesis is data from the PETS trial. This is another randomized controlled trial on the effects of adenotonsillectomy in children with primary snoring. It's an American study, and I think, but I'm not sure, the paper is being written now or is under review, so hopefully we will get the results in 2024. But preliminary analysis of the PETS trial showed that even in children with mild sleep-disordered breathing, a longer sleep duration is associated with better neurocognitive functioning. So this is something that we can also do, that we have to protect sleep and that we have to acknowledge the importance of sleep and a long sleep duration, even in children with mild sleep-disordered breathing. So the situation becomes very, very complex. We know that the apnea-hypopnea index is not the best marker. Snoring could be an important marker. We certainly need biomarkers. We have modulating factors, either predicting persistence of resolution of obstructive sleep apnea. So the main difficult question is, who should we treat? Who and how should we treat? And even after treatment, is this associated with recovery? Now, what we find very important in Antwerp is that regardless of the severity of obstructive sleep apnea, it is essential that you should aim for a correct and successful treatment in 100% of patients. We know that adenotonsillectomy is the main, but not always the correct option, and there are alternatives. And here it's very important that we use our clinical assessment. For instance, if you have small tonsils, think about something else. Also, the upper airway is not a black box anymore. We have easy access to tools, for instance, drug-induced sleep endoscopy, that can assist us in the treatment of every child with sleep-disordered breathing. And a question that I still have with the side effects that we now know of Montelukast is, are we still using anti-inflammatory medications? So this is some of the data in DICE. This is one of our papers on the usefulness of DICE in surgically naive children. And you clearly see here that the majority of patients, about I think 85 or 90%, will receive adenotonsillectomy. When you're surgically naive, you're a normal child, you have a 90% probability of ending up with adenotonsillectomy. But still you have 10% of patients where the surgery would not have been effective, and you need to look for another option. The situation becomes more complex when you include older children, adolescents, and especially obese adolescents. This is DICE findings set out to the age of the patient in the x-axis and to the BMI Z-score in the y-axis. And I would mainly like to focus on the triangles here. These are children who exhibit a circumferential collapse, which is the main DICE finding that we see in obesity. And you clearly see here that the older the children are, so in adolescence, and especially in obese adolescents, there's more circumferential collapse. So also here, these children will not benefit from adenotonsillectomy. And you can also see what happens in those children with smaller tonsils. This is data from one of our imaging studies of the upper airway, and we could clearly show that here in also normal children, that when you have small tonsils, either assessed clinically by just looking in the throat or by fancy imaging methods, small tonsils are associated with a suboptimal response to adenotonsillectomy. These children need to be sent for another treatment. And this has been confirmed by a recent study using DICE in children with obstructive sleep apnea and small tonsils. And you could clearly see that they confirm the same findings. Small palatine tonsils were infrequently identified as a contributor to airway obstruction, and thus tonsillectomy was avoided in most cases. But then sometimes you have the critique of perform adenotonsillectomy elsewhere, perform adenotonsillectomy, do it, because even if you are obstructing at different zones, when you remove the adenoids, when you remove the tonsils, also those zones will improve. This seems not to be the case. We don't have a lot of data on this, but this is another very recent study looking at DICE before and after adenotonsillectomy in children, and it clearly showed that also after adenotonsillectomy, the same zones that were obstructing the airways before surgery remained obstructive after the surgery. So adenotonsillectomy does not have an influence or does not have an impact at the obstruction of the upper airway in other zones. So for treatment in mild OSA, yes, adenotonsillectomy works, but it's not a solution for all patients, and the upper airway is not a black box anymore. So even in mild OSA, relative simply tools can aid us to select the most appropriate treatment. And either you perform DICE in all patients, that's what we do in Antwerp, but if you do not agree with that approach, then I think you have to select the patients based on age, BMI, and tonsil score. So if you have an obese adolescent, do DICE. If you have small tonsils, do DICE, and then select the most appropriate treatment. Is there more to come? Perhaps yes. This is an abstract, but also a recent study that was published on medical treatment using the combination of oxybutynin and atomoxetine for obstructive sleep apnea in children with Down syndrome. We all know that especially children with underlying conditions, the management can be challenging. A lot of these children will end up with CPAP treatment. They can be perfectly compliant, but there's a subset of patients with very difficult CPAP tolerance. So perhaps, we're not sure yet, but perhaps medical treatment could be an option for these children. And this is certainly something that we need to investigate further. And we're slowly moving now to the obesity part of my talk, but I think one of the directions that we also have to take is shouldn't we also focus on treating the linking mechanisms between sleep disordered breathing and end organ complications, and not only looking at neurocognitive complications, but also looking at obesity related complications. This is an animal study proving that concept. This is an intermittent hypoxia model where if you add antioxidants, if you add certain vitamins, antioxidants, then you can modulate the inflammatory consequences that are seen. So perhaps this is something that we need to consider in a subset of patients, a subset of children with sleep disordered breathing. And this is also something that we are currently researching in Antwerp. We have set up a translational model of childhood obesity and OSA. We have an animal model that we can expose to intermittent hypoxia, where we are measuring local tissue hypoxia and the downstream effects of that. We have adipose tissue biopsies from adolescents and young adults undergoing bariatric surgery. And then, of course, we have access to patients. And for instance, one of the trials that we are thinking on is melatonin, because melatonin has antioxidant effects in adults. It has been shown that it has cardioprotective effects, and of course, it promotes sleep duration. So I think this is a very interesting molecule to use, and we can test it in the obese animal model. We can test it in our adipose tissue biopsies, and then of course, as a last step, we can see if it has an effect in randomized clinical trials. So this moves us, this is the link to the second part of my talk, whether obstructive sleep apnea is relevant for pediatric obesity. And here we can use the same or an alternative graph, but it's you have not only you have obstructive sleep apnea, but you also have the obesity in parallel, and they both are linked, especially in adults, with several joint linking mechanisms: oxidative stress, inflammation, increased sympathetic activity, insulin resistance, adipocyte dysfunctioning, and so forth. This could all lead to an increased risk of cardiovascular or metabolic morbidity in children and adolescents. And the same that we are seeing in adults is also something that we see in children. This is one of our very first papers looking at the relation between obstructive sleep apnea and the metabolic syndrome in obese children and adolescents, where we could show that the severity of intermittent hypoxia during the night was independently correlated with the presence of the metabolic syndrome. And this finding has been replicated by a number of other studies. This is a study from Italy, where they looked at the relationship between obstructive sleep apnea and non-alcoholic fatty liver disease, which is the hepatic manifestation of the metabolic syndrome. And here you could also clearly see that obstructive sleep apnea is independently associated with the presence of fatty liver disease and is independently associated with significant fibrosis in these children and adolescents. This data shown graphically. You can clearly see here the BMI is here increasing, but with each quartile of BMI increase, if you're having obstructive sleep apnea, you have severe or you have more severe fibrosis on the anatomopathological classifications. In children, the relationships or the linking mechanisms linking sleep apnea with metabolic or cardiovascular complications specific to obese children are not that clear. For instance, in adults, obstructive sleep apnea is clearly linked to increased levels of high-sensitivity CRP. In children, the relation is not that clear cut, but as you see here, is that most of the research was done in a normal weight population. For instance, we could clearly show that CRP was mainly driven by fat mass, was mainly driven by BMI, and was not associated with the severity of obstructive sleep apnea. And the same finding is that we could show with when you look at certain adipokines, leptin, interleukin-6, adiponectin, and TNF-alpha. It was mainly associated with markers of obesity or central obesity, but not with obstructive sleep apnea. However, it changes when you're also looking at those children, what happens during weight loss. And for instance, this is data before and after weight loss. This is data looking at uric acid as a very crude marker of oxidative stress in these children. And you could see here that after weight loss that you have a significant decrease, you have a significant improvement in uric acid. And this improvement was not driven by an improvement in body mass index, but was driven by an improvement in severity of sleep-disordered breathing after weight loss. Also, a similar finding we could show in looking at endothelial function in obese children with and without obstructive sleep apnea before and after weight loss. So this is improvement in one marker of endothelial function before and after weight loss. And you see that in a number of children there's a significant improvement in endothelial function, except in one group. And this was the group with persistent obstructive sleep apnea also after weight loss. So even if you lose weight, but if you have persistent obstructive sleep apnea, you still have a worse endothelial function, and your endothelial function will not improve. So from these data, I think we can summarize that obstructive sleep apnea is independently associated with the metabolic syndrome, but the linking mechanisms are somewhat unclear in obese children. For certain linking mechanisms, it's clearly shown that obesity is more important than relatively mild forms of obstructive sleep apnea. However, it could become more clear, OSA could become more relevant after weight management or weight loss therapy. Now, let's also look at cause or consequence in the obese population. Also, children with obesity and obstructive sleep apnea, they show impairments in neurobehavioral functioning. And this is an American study looking at one aspect of neurocognitive functioning, and that is executive functioning. Executive functioning is very important for an obese patient. One of the key factors of executive functioning is inhibition. When you walk past the hotel buffet in the morning, that you do not take the croissant or the pain au chocolat, but that you take the fruit salad and a skinny yogurt. That is executive functioning. And we know that children with obesity, they have an impaired executive functioning, which is further decreased, and that is something that this study has shown, when you also have obstructive sleep apnea. And is this relevant? Yes, this is relevant, because this is another American study where they looked at dietary food choices that obese children with and without obstructive sleep apnea made while they were in the hospital. And it was clearly shown that obese teenagers with obstructive sleep apnea, they chose meals with higher fat and higher carbohydrate content. So they made less healthy food choices compared to their peers without obstructive sleep apnea. So looking at the direction of effects in obesity with obstructive sleep apnea, we know that obstructive sleep apnea could result in impaired executive functioning in children with obstructive sleep apnea. This could result, and we only have one paper, in suboptimal dietary decisions, which could perhaps lead to an unfavorable outcome of weight management therapy. Unfortunately, there's not a lot of research looking at the effects of having obstructive sleep apnea on the success of a weight management or weight loss therapy. But we could hypothesize that possibly obstructive sleep apnea could also impact, not cause, but impact the evolution or the natural history of children with obesity. So it's a bidirectional effect, and I think one that is very, very relevant. So if we conclude this part, is obstructive sleep apnea relevant for pediatric obesity? I think definitely yes. We know that obese children are likely to become obese adults, and that the development of cardiovascular disease begins in childhood. There's a vast evidence, major evidence, that there is an association between sleep apnea and cardiovascular disease in adults and children, but we need absolutely more data on linking mechanisms and on treatment studies. And an open question that we still have is, if you have an obese child with OSA, does this OSA also impact the weight management or the success of the weight management therapy? So the final part, the microbiome and OSA, really? Yes, really. A number of studies are being published looking at the effects of obstructive sleep apnea on the gut microbiome. This is one of the first studies published last year, a Chinese study, where here we will not go into detail, but you see that there are a number of bacteria that are significantly altered in the group of obstructive sleep apnea compared to the group with a normal sleep study. Is that relevant? Yes, that's relevant, because they also did the analysis of correlating these changes in gut microbiome with different pathways in our body. And I've highlighted two pathways. First, the insulin signaling pathway, so relevant for obesity and metabolic morbidity, but also here a pathway that is associated with Alzheimer's disease. Again, perhaps that we can make the hypothesis that an alteration in gut microbiome could also influence impaired neurocognitive functioning in children with obstructive sleep apnea. And I think it's a very interesting, but also perhaps a very relevant factor that we need to investigate further, but because of course we can also impact the gut microbiome, and perhaps this is also one of the additional treatment options that we have, so that we can stop the link between obstructive sleep apnea and end organ morbidity in children as well as in adults. And especially in the context of obesity, it's becoming more and more relevant, because obesity also impacts the gut microbiome. Perhaps obstructive sleep apnea will also impact the gut microbiome, and we know that the changes that you see in gut microbiome, they can have an effect on cardiovascular disease. So this is a very, for those who are interested, a very interesting review summarizing the limited amount of studies that we have reflecting the association between the gut microbiome and obstructive sleep apnea. And the authors, they concluded that it can be preliminarily concluded that intermittent hypoxia, one of the main features of obstructive sleep apnea in children, induces alterations in the gut microbiome, potentially leading it as one of the linking mechanisms between sleep apnea and end organ morbidity. Is it relevant? Yes, it is relevant, and I think this is one of my last slides, because you can have an impact on the gut microbiome. Again, this is an animal study looking at the effects of probiotics on cardiovascular effects in animals with and without intermittent hypoxia. So let's just focus here on the systolic blood pressures. You have your animals here. If you expose them to intermittent hypoxia, you have an increase in your systolic blood pressure. However, if you're using probiotics, you do not see that increase. So probiotics here could have a cardioprotective effect in the context of intermittent hypoxia, in the context of sleep disorder breathing. So for me, these are very, very interesting findings, and I think this is certainly one area that we need to investigate further. So to conclude my talk, I will mainly end with several open questions. I think from my talk, I think it's clear that we need tools. How can we improve our diagnosis of obstructive sleep apnea syndrome in children? I think it's very, very essential that we take the syndrome into account. Not only focus on the numbers, but also focus on the risk of complications, on the risk of morbidity. To that end, which useful biomarkers can we use in daily clinical practice? How do we adapt our treatment to this approach, especially if it's proven in the next coming months or years that also primary snoring is significantly associated with neurocognitive morbidity? And very important in the clinic, how do we individualize our treatment for all patients regardless of obstructive sleep apnea severity? How reversible are structural brain abnormalities? Because I think this is something that's very troublesome for parents. How reversible are structural brain abnormalities after treatment? Do we need other treatment strategies with somewhat a shift towards linking mechanisms, considering OSA-related complications? Perhaps the most relevant ones are those in the context of obesity, where we try to modulate or to protect our body from the effects of oxidative stress, inflammation, but also perhaps probiotics in the context of modulating the gut microbiome. That was my last slide. Thank you for your attention.